Good evening, everybody, and welcome to this in the series of SMMGP premium webinars. Tonight we'll be looking at setting up services for people with dependency on prescription and over-the-counter medications. I'm Steve Brinksman. I'm a GP in Birmingham, and I'm the medical director from SMMGP, and I'm delighted to have you with us here this evening. This has been a very, very popular webinar, and an awful lot of you out there, so that's great to hear. And before we start, I must thank Camerus for an unrestricted educational grant, which has enabled us to provide this webinar for you tonight. This webinar will be recorded, and a link so that you can access it later will be sent following the webinar itself. I hope that some of you will be tempted to come and have a look at some of the other webinars we have for SMMGP under our premium membership, and this is a facility that's also available for all people who are members through FDAP. So the way we're going to start this tonight is we've got a talk from Graeme Dixon of Agencia. Agencia have a 20-year history of innovation and service change and transformation in both criminal justice and the health service, and this is going to be looking at a lot of the work they did with their Rewire project in North Lincolnshire, and Graeme's going to talk us through that. Before that though, we have a couple of questions for you, so we'll get the first of our polls going. So we'd like to know what's your role? Please select one of those, and if we get through this quite quickly, and I can see those results coming in. It's a bit like Thursday night's going to be, and it's tight. So there we go, and we have the polls now closed, and there we go. A third of you are doctors, nearly a quarter are nurses, a small number of key workers, and lots of key workers, pharmacists, and others, which is great. And then just go to our second question. So what I'd like to know is, where you are, is there service provision for people with prescription or over-the-counter medication problems? Yes, no, or you don't know? Thank you. Okay, there we go. So almost half there are, but a significant minority there, 34%, so there's definitely no service in your area. So hopefully when we get to the end of tonight, we may have some ideas about how we can start to move that forward and develop those services. So with no further ado, I'd like to hand over to Graeme Dixon from Agencia, and I hope you enjoy the rest of the webinar.
Hi Steve, thanks for the introduction. I'm Graeme Dixon from Agencia. We are a business change and transformation organisation, and we've been doing this for the last 20 years. And for the last 5 years, I've been either an employee or a director of the company, concentrating in the area of harm reduction and drug services. So without further ado, I will start the presentation. I believe questions are coming in at any point, so if you've got a question, just type it in, and Steve will basically pass those on to me. Please feel free to put those in, because that'll make this much more dynamic. And about halfway through, I'm going to hand over to Paul, who's got lived experience of the of what it's like to actually suffer from opioid or analgesic dependence on the back of their prescribed medication. It is a real insight. And before I actually start, I would also add that one of the things that's kept us doing this so intensely is the reaction we have had from patients, and the level of both worry and appreciation they have, both them and their families, for the service we've been able to provide. So here we go. Firstly, I thought I'd start with this slide, which gives a picture of where there's high levels of opioid prescribing across the UK. And as you can see, in fact, it's across England. And as you can see, it's a bit of a north-south divide, but there's a lot of high levels of prescribing in the more deprived areas and also on the coastal strip. So it just gives you an idea of where the problems are concentrated, and you might like to think about why that's actually the case. So why did Rewire start? Well, this goes back a while. Back in 2014, one of our commissioners in North Lincolnshire really began to get concerned. He went to a conference and what was happening in the States was highlighted. And we could see that definitely had potential to be happening here. So we got some funding in with the local authority, and we did initially a survey to identify what the prevalence was like locally, and that was carried out by our commissioners. And we looked at what best practice was, and that wasn't just here. We looked across the country, we looked at all the academic evidence, and we found that on the whole, there wasn't a lot of structured care in place, and there was a lack of awareness of this type of patient. Often they don't fit well into a drug service. So how are people who have a problem with opioid analgesics going to be identified? We ran the service, we set up Rewire, we got going, and we won an award at the Royal College of General Practitioners Substance Misuse Conference, sponsored by the SMMPG, and Kate was kind enough to give me that award, so thank you very much, Kate. And we also then applied for a fund from Public Health England to create a specialist centre in North Lincolnshire. One of the things about this type of work is funding can be an issue, so we have applied so far successfully for social investment from the Life Chances Fund, and we're hoping to start a larger scale project in the new year. So what was the process? ORAT, that's the opioid risk assessment tool, and it gives a picture of who is at risk from opioid prescribing. So it'll look at things like whose prescription is increasing, what type of diagnosis people have they had issues perhaps with alcohol or other addiction in the past, have they had a previous diagnosis of cancer which is now being cured, have they got a long-term condition? So all those things are assessed and prioritised, so it gave us an idea of who was actually prescribing within the general practices we reviewed. It's a very, very powerful insight into what's actually going on, of how people are being prescribed and what the possible issues are. And one of the things that we really saw from this was the power of data to actually allow us to take a lead in how issues were addressed, rather than simply waiting for things to happen. Now, we filtered the results, and all the results were assessed by a very experienced pharmacist who may or may not be actually listening to this. If he is, thank you for all your help and assistance, Adrian, and your expertise was of huge use. And what that gave us was a level playing field. We were able to assess what was happening and identify those patients most at risk and how we were going to address them. And we had a lot of support, not just from the from the GPs, but also from practice managers in the practice where we were working. We invited people in and the medication was reviewed. But we also, as part of that, had support from a psychosocial worker, and we assessed people's risk of addiction. And that's important because there's a lot more to this than simply saying the way to avoid over-prescribing is to cut people's prescriptions. Once people have addiction or a tendency towards being addicted, the game changes. And being aware of that and how you handle that has really been a critical part of the learning from the Rewire project. So what did we do? Well, we created a series of letters that invited people in for a medication review after we'd ran the ORAT tool, and we got them in for their first session, which was usually with a pharmacist or a GP. The nice thing about these sessions was we had a little bit more time than a standard 10-minute appointment, particularly when we were using the pharmacist and the psychosocial worker. So these initial appointments could run for up to 40 minutes, and that gives you time to really go into depth and explore what is happening with the patients. We use the POMI tool, which I'll come to in a minute, just to assess the risk of dependency, and that again is a very useful tool. It stands for Prescribed Opioid Misuse Indicator, by the way. As this is a lecture about medical practice, I have to have a number of acronyms in, otherwise I get arrested. We used a standardized assessment form, so we knew exactly patient history and how they scored in the POMI, what their risks were. And we also used frames as a way of identifying, to inform patients about their risks and options for changes. I hope people are familiar with frames. It's a nice validated methodology for delivering behavioral change. So the first one, feedback, that covers your risk of dependency, and obviously that's informed by POMI. Responsibility, in the end, if we're going to have behavioral change, it's the patient who's got to lead and drive that. The A is for advice, which is providing an appropriate level of advice around the risk. Menu, M, what are your options? And finally, the psychosocial elements. Empathy, we really did focus on building a strong relationship with patients and understanding that there's a lot more to why patients get to where they are than simply the level of prescribing. And finally, having a lot of confidence that the patients can and will make changes. Once we'd gone through that process, which was far less painful for the patient than I hope it is as I explain it, we would then initiate treatment, including, if necessary, opioid substitution therapy or a reduction plan and tapering. Our GPs would look at alternative medications, or we'd provide brief advice. So this is the patient opioid misuse indicator questionnaire. I hope you can read this all right. I don't really want to talk through it, but as you can see, there are 7 questions there. And we found lots of indicators. Early refills. There are clearly a lot of dogs who eat tablets. No question, when we're discussing with patients why they need early refills, then the dog ate my medication was quite a common thing. The dogs obviously have significant resistance to pain medication. Again, are people using more often? We could identify that through the ORAT tool and see if there was a trend, the same as if people were moving up the prescribing scale. And do people get a buzz? Why are you taking it? The crime survey of 2015 of reports indicated that there are literally millions of people taking painkillers simply for the buzz. I think it was about 2 million in 2015. So taking your medication for the buzz is obviously a concern. Do you use it to manage your emotions? Again, when we were looking at this, we found a lot of evidence that painkiller misuse was actually quite common among high flyers who were, particularly females, interestingly, who were using it to manage stress. And finally, you'll all be aware of doctor shopping, where patients go from one GP to another, from one practice to another, or go around the pharmacists, identifying people who will prescribe their medication of choice for them. If any 2 of those are a positive response, then that indicates that the patient is at risk of addiction to pain medication. So if you look at this, it's actually quite a low bar, any 2. So what did we put in place? Well, we had up to 6 sessions. Some patients needed more, some needed less. And that was a psychosocial session. And we did things like, often people weren't aware of the dangers of some of the power of some of the drugs they were taking. So where are they storing them? Are they being kept out of reach? We did talk about naloxone, which is used a lot in treatment to reverse opioid overdoses. As some of the patients we spoke to were actually quite concerned about how out of it they were. We went a long way into care planning. What steps are you going to take? What's working for you? And confidence and trust building. This is difficult for patients. After all, this is not some kind of illicit substance. This is a prescribed medication. They don't expect to have problems, and you can see why they were very concerned. In fact, we'll go on to that in a little bit more depth later. What other techniques can you use for managing pain? Can you accept a certain level of pain? What time do you take your medication? Do you take it when you feel your symptoms? Do you take it as required? Is there a bit of a ritual around the patient? Are you around taking your medication? Is there almost a pleasurable anticipation? And if so, why? What are your resilience and coping skills? That's really important, particularly if you're using the medication effectively to help control your emotions. And of course, if you reduce your medication, if you taper, if you change, how are we going to stop going back to where we first started? And those proved to be critical for the majority of the patients that came into treatment, and again, greatly appreciated. We really did focus on working to a validated behavioural change model. As I've mentioned frames, but also we did a lot of work around making every contact count, and we were able to incorporate that into the practice around, you know, what works for you, what will help you change your behaviour in a way that's best for your health. And also, things are changing. We're looking to have patients take much more responsibility for their treatment, be much more engaged. So what will create patient activation, get them involved in their own treatment? How can they navigate their way around the system? And also, do the skills to help them navigate exist within practices? And also, of course, we followed Public Health England and NICE guidelines. And we worked with the practices to create an environment where this could all take place in a way that fitted with what you already did, because there's very little point having a system change that doesn't understand staff are busy, GP time's limited, patients are busy. You have to actually make whatever you're delivering fit within those very difficult criteria. I'm just going to go on to case studies now, but what I would like to do is hand back to Steve so we can introduce our patient with some really significant lived experience, Paul.
Thank you, Greg. Actually, just before then, we have had a host of questions come in, so I'd like to just run a few of them by you first before going to Paul. If that's okay. Mainly because some of them are around the POMI particularly. Now, the first one was, is the POMI a similar concept to ORAT?
Yeah, the ORAT is the ORAT runs over a database. So the ORAT is simply run across the patient records. So it identifies, basically, it looks across the treatment record and identifies things automatically. So the ORAT is an automated tool. It's just a computer program that runs over the database. The POMI are the questions that you ask face to face.
Yes. So ORAT is basically looking at the system and finding people who might be at risk, and POMI is used with the individual patient to assess what their individual risk is.
That's correct, yeah. Spot on.
Oh, that's great. And so the next question is this questionnaire, is the POMI available to use freely, and where do we find it?
Yeah, the questions are here. It is available to use freely, and I can certainly I'll make sure that the questions are up on the website, so you can see exactly what it entails.
Excellent. That's really helpful for everybody.
There's also, if anybody's interested, there's a huge amount of academic research behind it as well, which people may find interesting.
Yes, the next question was, is the POMI validated? And of course, that's something that everybody needs to know in this evidence-based age.
Yes.
Indeed. Okay, great. Well, thank you very much, Graeme. We look forward to coming back to you as you go through the case studies. But first, I would like to introduce Paul. Paul has very kindly agreed to come and take part in this presentation. And Paul has very real lived experience of prescription and over-the-counter medication problems. And I'm sure what he's going to say is very, very powerful. So without any further ado, Paul.
Thanks, Steve. Thanks, Graeme. Good evening, everybody. To start off, I was born and brought up in a small market town in Derbyshire. Worked every weekend from the age of 14, left school at 16, straight to a full-time job. Worked for the same company for 26 years. I started off at this company in about 88, I think it was. I was hand stacking every concrete paving product for about 10 years before manual handling was an issue. And I injured my back one morning, and I went for physio, had a couple of days off work, and because Money was tight at the time. I went straight back to work and just got on with it. Always been brought up to work hard for all my life, and work hard for what I need and things like that. So it wasn't until I was promoted many times with the same company. I started off as a team leader, then went to assistant factory manager, then factory manager, and then I was running my own site in Leicester. There was a lot of travelling involved, so the problem with my back started to get worse over the years, and I went for an MRI scan, and it showed degenerative disc disease in 5 discs in my back, 2 in my neck as well, and the pain was really bad at the time. I went through certain medications that didn't really help. I was put on oxycodone, and that really helped at first. It gave me some quality of life back in the beginning, but then it stopped working, and I went back to my doctor, go up the dose. Same thing over many months, kept working for a while, then stopped, then up and up and up, until I was switched to OxyContin. Exactly the same again. The dose just kept spiralling due to what I later learned were tolerance levels. And in the end, I think it was 800 milligrams a day I was prescribed, but I was taking double that, because the pain will come back, which I thought was the pain at first, coming back after about an hour and a half, 2 hours. But in fact, it was what I later learned were withdrawals. So I kept eating these things like Smarties. My loved ones around me kept telling me I've got a problem. Well, I was in denial. Can't be a problem, it's prescribed, it's fine. It wasn't until I was actually working away once that I took my script into a different pharmacy. And the pharmacist rang the GP surgery up to check the amount. And when she got it confirmed, she handed me the script back and said, "I'm sorry, I'm not dispensing this. I'm not going to be held responsible for your death." And I got thinking, what's going off? This is when I started to look into what OxyContin was. Lovingly named hillbilly heroin in America. What's fueled the opioid epidemic in there. I'm sure that a lot of you are aware of how many millions have been and still ongoing in lawsuits against the manufacturer. So I started to assess what was going off and just find out how I could get my life back, because it was controlling my life. It was the first thing I thought of in the morning, the last thing I thought of when I went to sleep at night. I'd get up in the early hours of the morning, pacing up and down, how I could work out how to pick my prescription up 2 weeks earlier than I needed it, because I'd used them all. My partner used to hide them from me. I'd find them and take them. I didn't use the one about the dog, Graeme. I didn't use that one, but I did say that, because I was working away a lot of the time, but I was saying that I was working away when I wasn't. I'd lost my script a few occasions, that type of thing. Just making up any excuse just to get that script. I was always brought up to be very honest, treat people with respect, but I found myself lying and being deceitful. But at the time it didn't matter, because as long as I got that script, that's all that mattered to me. I was involved, I had injections in my back, that didn't work. I was involved in a car accident on my way home once, on a road that I drove every day, and I heard a bang on the back end. The car stepped out on a bend, and it clipped a car coming the other way, and the wing mirror came in through my window and smashed on my eyebrow, and I blacked out. And I went to the hospital. They cut the glass out of my eye, the eyebrow, and round my eye. And the nurse asked me what medication you on, how long you've been on it, and when I told her, she thought I made a mistake. But my partner confirmed the amount. And then I lost my job. I was operations manager at the time, and I lost my job. And I was on my way home just thinking, what do I do? What am I going to do? How am I going to pay the bills? I've got everything I'd worked all my life for. I didn't need any money. I've got no money issues. And I thought, well, I need to do something. And I refused to claim benefits because of an inner pride of how I worked hard all my life. But I did end up claiming benefits in the end, and I have done since, because I used all my life savings before I claimed benefits. I went back to my doctor, said I've had enough, I want my life back. My partner kept saying that I was doing these things. I can't remember. She even said that when she went to get my tablets one day, there was hardly any left. Where have they all gone? And I actually said to her, somebody must have broken in the house and stolen them. And looking back, I just think, how? What was I doing? How could I say that? I've been off. I started a tape. I changed doctors, and because I moved house, and I started a tape program in August 15, 2015, and I was doing really well over the months. I got down to a dose of 320 milligrams a day, and that's when I hit a brick wall. I couldn't physically drop anymore. I was depressed. I was anxious. I didn't know what to do, and I later realised that it was due to dopamine because I've been getting it so long. I think it was over 7 years I was on Oxy. I've been getting it so long off OxyContin, my brain stopped producing it. So when I dropped down to a certain level, the brain was no longer producing it, and I wasn't getting it from the Oxy either. So hence the depression, bad moods, things like that. So I went to 3 drug clinics, local drug, well, in Derbyshire. Every one of them turned me away to say, it's not heroin, we can't help you. And because of the research I've done, I kept saying, it is heroin. It's synthetic, it's manufactured. And they said, well, it's not illicit, we can't help you, go back to your doctor. So I was sent around in circles, basically, from doctor to pain clinic to drug clinic to pain clinic, back to my doctor. And it wasn't until I found a drug charity in London called Release, especially a young lady there, saved my life, because she got involved. And she managed to persuade one of the addiction psychiatrists that first turned me away to help me. And this was after so many weeks of backwards and forwards. And the reason he agreed to help me was, he said, I'm only agreeing to help you because out of the goodness of my heart, because I'm not being paid to help you. And I couldn't understand that at the time. So I was told I've got to stop taking 320 before I could get the help. I stopped taking the 320. I was started on 30 mils of methadone. That was where my problems really began, because I was no longer taking any oxy at all. The methadone only held me for an hour and a half, and I went straight into withdrawal. And this carried on for weeks, and then I was put on to 50, the same again for weeks after that, on to 70, same again. And this went on for weeks, constant withdrawal, forcing yourself to eat because I lost so much weight, coming out of every orifice that I've got, no sleep, restless legs, sweat, shakes, hot, cold, worst flu symptoms times 10. Is sheer hell, and I never want to go back there again. And eventually, when I got to 105 mils, I was stable, and I started to have some quality of life back. My pain was still there, but I refused to take anything to deal with it. I was diagnosed in 2016 with severe sleep apnea, and I was stopping breathing 80 times an hour a night. I had a brain scan to check the pituitary gland. Thankfully, that was okay. So I was put on CPAP, which made it worse at the beginning. And then the sleep clinic had to get funding for an ASV machine, which treats central sleep apnea. But I'm sure you're all aware, central sleep apnea is the one where you stop breathing, your brain says, you stop breathing, I'm not telling you to wake up, it's up to you, which is quite frightening. So yeah, this went on, and I also had blood tests because I just didn't feel right. My testosterone level, according to the endocrinologist, was in my boots. I started on hormone injections. They started to thicken my blood and brought me out in acne, so I stopped taking that. I was given different types of antidepressants, but I refused to take any more because 1, they didn't work, and 2, I was worried about what they were doing to me. It wasn't until March last year when I had another full blood count, and this time it showed up pernicious anemia, B12 deficiency, folate deficiency, and macrocytic anemia. And I had the injections. The BNF guidelines say 6 loading doses over 2 weeks, and then 1 every 3 months. But it didn't help. The only time it helped was after keeping a diary, was say 2 days after the first 3 monthly one, but for only 2 days, then I went straight back down again.
Paul,
exactly the same with, yeah.
Well, we've just only got a couple of minutes here, really, because we need to push on with the time limits. So
yeah,
sorry
to
do a little bit.
It's all right. I'm just about done, Graeme. So now I have to self-inject. I've never felt better. I've been self-injecting every day since Christmas, and I feel the best I've felt in years. My mood's loads better. My sleep pattern has vanished after another sleep study. And I've looked at it, it's all down to the opiates, because opiates obviously suppress breathing. Now, what I want to do now is just to raise awareness about what these drugs do to people, not just at the time, but long-term health conditions as well. And now, obviously I'm still not working, but my passion is to help others. I think mainly through prevention and education more than anything. I'm currently volunteering with Derbyshire Recovery Partnership to look at helping addicts there. But my main passion is to help people addicted to prescription medications and trying to prevent what happens to anybody else. I've just completed a course at the pain clinic, so I've still got the pain, as I say, but I'm in a much better place now to deal with it. And I'll use mindfulness and relaxation, so that's what I'm doing now, and that's where I am now. It took everything, but I'm still here, thankfully, and I'm lucky to be here. And the services still don't help people like me in my area, so that's what I want to change, but I don't know how, because the government don't commission it. So that's why I'm interested in what SMMGP are doing. So that's me, Graeme.
Thank you so much, Paul. That was really amazing to listen to, and none of us can really understand what you've been through, but hearing it from you like that will help to put us into context when we're dealing with our patients and realizing some of the things they're struggling with. And in fact, one of the comments came through was that it was Paul's story is amazing, very indicative of his problems. I'm impressed by his knowledge of opiates, and does he want a job? So
absolutely, I'd love one. Thank you.
What we're trying to do here, and lots of others, thanks for your story, Paul. Lots of people appreciate you taking the time out and being able to, prepared to put yourself out there to help us to understand more and help others who are in your situation. And what we're hoping to do through this webinar and the other work we're doing with SMMGP is not only highlight this problem, but to be part of the solution in developing, effective answers to problems for people like yourself. So thank you very much, Paul. And with that, I'd like to hand back to Graeme. Thank you.
Hi everybody, that was very inspiring, Paul. One of the reasons that when we started this, we realized there were so many cases like yours out there, and our aim was to stop people getting to this point. That was the real power of using ORAT and actually reaching out to people at an early stage so that they didn't go as far down the problem as is possible, and as I think is happening more than we realize. And the other thing I would say is that many of the patients we saw would really have struggled to engage with traditional drug and alcohol services. They would not feel they were the same type of addict, and the services aren't really built for this. So here's a couple of our case studies. This is quite interesting. Again, somebody who worked full-time, was prescribed codeine quite a while ago, initially for toothache, then found other reasons to keep being prescribed painkillers. When the painkiller prescription was being reduced, he started adding Nurofen Plus and other codeine-based tablets to his menu, shall we say, and was spending a huge amount. Nobody had ever really talked to him about this, and one of the other things I would say is he'd also been to hospital a couple of times for investigation to gastric problems, and had never mentioned the amount of opioid he was taking. So he'd been at least 3 times, to my knowledge, possibly more, for investigation, and had never disclosed the level of opioid he was taking. Because of the amount he was taking, he did go on to methadone. He wasn't on for very long and is now completely drugs-free. And the other thing, he's £400 a month better off on the amount he was spending on his drugs, and his reward was to take his wife on a cruise, which he was, I believe they were both very happy about. The next one, once the service was up and running, people started coming to us, and that's worth mentioning as well. Once there was something in place and the word got out, GPs would start making calls to the service and say, would you just take, who weren't part of the pilot, who didn't have the ORAT ran, but knew we were operating, would start saying, could we just send this patient to you? And this is what happens when there is something there that people trust. This client was basically topping up her medication on the dark web and using a significant amount again. Once again, the level of addiction meant that she had to go onto OST and became drugs free. So I haven't amended that slide correctly. But what was interesting was her mum came to support her, and it turned out she was so concerned about her own misuse of cocodamol, she entered the service as well. So let's look at outcomes. We went out to 200 odd patients, and what was interesting was when we called people in and used the POMI, or patients who were referred, who came through self-referral referred by pharmacists, about 10% of them ended up going to formal treatment. And it's worth, in opioid substitution therapy, and it's worth noting that usually in most services, the majority of clients are male. Because we reached out to patients and said, are you concerned? The split was basically 50-50 between males and females. And I think that's a really important piece to take away from this, that if the risk is exactly the same, but by being proactive, you can get patients to engage who perhaps wouldn't. 9 with drug-free discharge, I believe that's more now. We also found that a lot of patients changed or stopped their prescription, and we did follow up on that and found that they weren't suffering. They were simply prescriptions through habit. We also found structured brief advice was very powerful. People simply didn't realize the risks they were taking, and once that had been explained to them, either worked with the GP to find a more suitable painkiller, or actually reduced themselves with supervision and came off completely. We trained a lot of people. We had a great response from the local pharmacists who came to a couple of evening training sessions. Again, doctors came to training sessions, and we also went around the local area. And one of the interesting things we found was training the reception staff proved invaluable. When we started this, I think a lot of people were worried about how patients would react. And we found on the whole, they had concerns as well, but it was what was prescribed. They were happy to keep going. They really didn't understand what the potential consequences of long-term opioid use could be. And one family was certainly interested in training on naloxone. But the key thing was the brief advice worked well. This was not a service that required a lot of complex psychosocial support. The vast majority of patients were appropriate because we got to them early, we dealt with their concerns early, they were able to change their behaviour, and that was the main aim. After we ran our first practice, the reception staff said they'd had a lot of issues because we were doing some follow-up with patients who were really concerned about why they were being called in and concerned they might lose their prescription. So we spent a lot of time then training reception staff, and that was very, very well received. And of the patients, we found very little resistance. The legal implications, these slides have been provided by CAPSIC, so I won't go into too much detail about them. But as you can see, there is significant litigation going on, and I suspect that with the end of the various, what's the right word? I was going to say PIP, but the various case against the banks, these solicitors are going to be looking for something else to do, and I do believe there's a significant litigation risk lying just behind of patients actually suing. There's also a professional risk, and coroners are very, very aware of the risk of mixing various strengths of painkillers, and how drugs interact. So this is a case, 2016. CAP6 represented the family and the GP involved in this case. And as you can see, there is a very significant risk if it is felt that you are prescribing inappropriately and if somebody dies. And we're very aware that there's more of these cases going forwards. And it builds up. Some of the patients are incredibly good at persuading you to increase your prescriptions. If you listen to what Paul said, with a little bit of consideration, probably Paul wouldn't have got to where he did, which was heavily addicted to painkillers. And I know Paul mentioned in a previous conversation that at one stage he was actually looking for a heroin dealer. I'm sure you won't mind me sharing that, because that is one of my big fears. If we simply say, oh gosh, we've got a risk, we're going to cut our prescribing down. That is what drove a lot of the transfer in the US from prescribed medication to heroin. So it needs to be really well balanced as an approach. These are some of the clinical features of painkiller dependency. I'm sure many of the GPs are fully aware of these. And these are some of the costs which what led us to this, particularly in North Lincolnshire. As a rough guide, we were prescribing about 3 times the national average. Now, part of that is because of the industrial history of North Lincolnshire. But as you saw from that early map, we're quite a deprived area. We're northern. Does that level of deprivation have an impact on the level of prescribing? I'm fairly confident it does. And one of the other things that we all need to remember is that pain medication has a different effect depending on how people are feeling. So their emotional stability can also affect how much painkiller they need or how much they feel they need to manage their pain. And again, that was simply another example of how much the potential savings are simply by following best practice. Now, here's some resources which you may want to tap into. Opioids Aware, fantastic website. It's just been updated. It's the link is here. And also, if you want to know what your prescribing practice is within your own practice, openprescribing.net is a very, very powerful resource which shows levels of prescribing by practice, by CCG, and by area. And I would strongly recommend you have a look at it because it gives you a lot of information. As I've just said, pain intensity can relate to anxiety and distress, and pain is very, very difficult to manage. And I quite like this quote. We really need to understand why the prescribing is taking place. Our project was very much about trying to get additional time for GPs and additional time for patients so that we could use data, be intelligence-led, identify those who would most benefit from an interaction and a bit of extra time, get them in and put them in front of people with the skills, be they doctors, pharmacists or psychosocial worker, who could really, really help. There's a tremendous amount of powerful data just sitting there within your practice that can enable you to actually reach out and be ahead of this game rather than behind it. And putting facilities in place that support these patients will, in fairly short order, save money. We saw significant savings just in the net ingredient costs of the drugs. And with the advent of SNOMED, for those of you who are into sort of the data, there's a lot more information now readily available. We started this as a pilot, and we started it as a way of identifying the scale of the problem. Very quickly we realized that the problem was there, and what we tried to do then was focus with Rewire on putting a solution in place. We were fortunate. We had the skills with a great pharmacists, great GPs, and psychosocial workers who've had some experience of helping people with benzos. Were able to build a service that actually worked for the patients. And we've kept doing it long after the funding and other bits and pieces ran out, because we saw patients like Paul. We had letters from parents saying, "You have changed the life of our son or daughter." It really is an opportunity to make a difference to patients, and setting up the service it was challenging, and it continues to be challenging. We're seeking additional funding. but it's been one of the most worthwhile things I've ever been involved in. And you genuinely see the impact this can have on individuals, their families, and the overall health economy of your area as well. So that really finishes the formal bit of my talk. I'm sure there's going to be loads of questions. I hope there is, and I hope everybody's enjoyed it.
Thank you, Graeme. Yes, there are loads of questions, and we have just under 15 minutes before we need to wrap this up. So that should give us time to get through quite a chunk of these. So going back to one of the things that you mentioned in your case studies, one of the questions here is, do you see that online prescribing or ordering medications at a distance is a major problem these days?
It's got the potential to be a major problem because it's just yet another source. Certainly some of the patients did order their drugs online. Some from illicit sources, others were using online pharmacies. We had a couple of cases where they'd basically done their orders through online pharmacies, then came in to see us after they'd spoken to their GP. So yeah, there is a risk. It needs to be carefully managed.
Okay, that's it. And obviously you had a number of people who went on to OST, and it was quite appropriate to talk to those about naloxone, and you also discussed that with a number of the other patients that came to see you. Did you have any sort of criteria around provision of naloxone, or did
we ended up not providing naloxone, but there was a couple of patients who, when they were saying how out of it was, it came up in the conversation, but we didn't actually then go on to provide to the families.
Okay.
So had there been a greater level of interest, I think it's something that might be worthy of consideration further down the track in any as part of the prescribing practice, but it was something that came up, and because I don't think people realise the risk of overdose.
Indeed, yes. I just think that when we start to put people onto OST, opioid substitution treatment, then I think it's something that we as clinicians certainly need to be aware of, because most certainly working with people who are using illicit opioids, it would be considered best practice. So yeah. I think something that probably is for those who are looking at setting up services probably should be considering.
Yeah, definitely. I mean, we not in this particular case, but we had people whose lives were saved by using naloxone in North Lincolnshire.
Indeed. And then going to that, I've had another question here around the ORATs, which I think that there's a lot of interest in, but is that something that could easily be run by a GP within their own practice, or within a PCN or a CCG, or does it need someone from outside that primary care network to come and set this up?
Well, that's an interesting question. When we first did this, you needed somebody from the outside, and with the move of this from Reed onto SNOMED, we've put a lot of effort into getting this redeveloped, and it could be ran within a practice if you've got the appropriate skills. It's not that straightforward, but it's not a huge issue to actually install and run over the database, and it can be fully anonymized. So it could be ran and the information fed back to the GPs. So it's new. It was very new when it was done. There's been a big change, but that change has actually opened up a lot of other options in terms of the level of data you can put together. So not a simple answer, but it's definitely there and it's doable.
So it's a possibility. Also, what would be a nice possibility, Graeme, people are saying is, could they see you again? Any chance of, they've just got my ugly mug at the moment, so we could share the pain for them if you can turn.
Oh, absolutely, yeah.
I think it's on there somewhere.
So I'm not quite sure, what was the...
Your webcam. No, we can't see you, my friend, I'm afraid.
Oh, hang on, it was muted, so let's just have a look.
No, we can hear you, but we can't see you.
I've just hit the share button again. Oh gosh, there I am. That's a bit scary. It's the Christmas lights in the background.
Well, it's Christmas. We can enjoy that. Okay, that's great. There's an interesting. There's a view among some of our watchers that perhaps substance misuse services are the best place to support this group of patients. Obviously, you're advocating working within the primary care setting, And there's also a sort of, is there a stigma with traditional substance misuse services for this group of patients as well? So how do you feel that there's an advantage to one over the other?
It depends where people are. I mean, with the complex cases, with high levels of addiction and complex behaviours, those are definitely most appropriate for the substance misuse services, because that's where the in-depth expertise is. For a lot of the patients who need a fairly quick managed withdrawal and have what I would call excellent recovery capital, and would be very uncomfortable about going to a substance misuse service, then having the skills in-house within the GPs or within a network of GPs, I think is a very powerful way of enabling those patients to engage in a way that's easier for them. It is a very difficult judgment to draw, but most of the patients we talked to made it quite clear they did not want to engage with substance misuse services directly, and felt that they weren't using anything illicit, so why would they need to? So that, yeah, the stigma is an issue, no question, and it's not a straightforward answer. But on the whole, because we're trying to get ahead of the game, it would be appropriate for these people to be managed, at least in the first case, within the GP practice, if the skills are there.
Yes, I think, unfortunately, the GPs are often better at up titrating rather than down titrating, and sometimes and we've all been there, and you know,
Yeah.
it's a difficult discussion to have with patients, and I think the additional level of support that's coming in by having workers alongside and pharmacists alongside is very useful. But I think some GPs will feel quite rightly that they don't have the skills to be able to develop this, and I think that's something perhaps we need to be working out alongside as well.
Definitely, but I think in terms of within a GP practice, possibly not, but within a network, then, you know, there may be possibilities to also use some of the skills more appropriately and over a wider base. This is under development. This is a new way of working to a certain extent, and I think my personal belief is the more work we can get done in GP practice for the patients, the stronger the offering is.
Yes, indeed. I think, yes, there's a view here that obviously the substance misuse professionals, you know, have all those skills around the physical management of opioids, and also the sort of the how to actively manage a withdrawal, but also the psychosocial input, looking at perhaps the trauma-led care agenda starting to come through as well. However, probably that it is the word addiction services that puts some people in this group off, and how do we try and check, because you know the illicit opioid users have been stigmatized for a long time, and I think that sort of feeds into this a little bit, doesn't it?
Yeah, I mean, I think my hope is that if we operate in a way that's intelligence-led, we stop the vast majority of patients, because the real impact of this, while we had to put people into opioid substitution therapy, were all the ones who changed their behaviours that didn't have to go down that route, and were perhaps prevented from getting to that point where that became a necessity. And I suspect my feeling, if you look at openprescribing.net, the practice is getting better, but there's this big backlog of patients who have built up over many years who will still need help and support. So hopefully the prescribing practice will evolve and things will improve naturally, but we need to tackle this backlog.
Indeed. And also, you mentioned obviously Agencia do criminal justice work as well, and there's a very pertinent question here suggesting where would this approach, or what sort of approach do you think might work within the secure environment setting, where of course we do find high levels of opioid analgesic prescribing and potential misuse?
It's a very different game. And that, I mean, our criminal justice work is mainly overseas and setting up anti-corruption services and cybercrime. Within the prison setting, I've got some experience because I worked in the criminal justice area myself, and you would need to really look at how the prescribing practice works. A lot of our work was successful because we were educating the patients about the risks themselves, the motivations around prescribed medication in the prison setting is very different, and therefore this would not fit that naturally in that environment, although there's obviously a lot to be learned.
And another interesting one is, did you ask or screen this group of patients around alcohol at the same time? So were you finding concurrent alcohol use problems, or was that not part of the process?
We did look at previous alcohol misuse problems as an indicator when we were assessing patients to be called in for an assessment. So that's one of the criteria on the ORAT tool. We also, we would run an audit with them if we felt it was appropriate. And some of the patients did say they had an alcohol problem. We didn't see a huge amount of crossover, but I suspect that had we run the project for longer with more patients, we'd have experienced more of that.
Right. Okay, that's fine. And then the patients who went on to OST, were they on they were supervised consumption, one assumes, or yeah, and did they express any concern about that, or was that anything that they found?
We had to manage it quite closely with the pharmacists, because there were issues in terms of the time they attended and their own sort of experience of going to the pharmacist for supervised. So there was a lot of support given to the pharmacists to treat them appropriately. Probably sounds the wrong word, but to make sure they were properly looked after. And we made sure that they fed back to us about how the supervision was going.
Right. Excellent. And another question around the logistics of this: were you making was NDTMS reporting taking place with this group?
Yes, it was.
Right. Nice, quick answer, but that's good to know.
Yeah, I don't hate NTDMS quite as much as some people. I find it a very powerful tool for assessing performance.
Indeed. Okay. And then somebody was. Is there anywhere that this pilot has been sort of written up, and which the results can be found more in more detail, or is there any way we can make this information available to people? Because I think people are very interested in the outcomes that you had, and of course, nicely that total drug-free isn't the only outcome. That's an improvement.
No, far from it.
Exactly, and that's, I think, that it's good for people to have the opportunity to look at some of those other outcomes that make real difference to people's lives, even if they're not headline in terms of abstinence.
No, I'm quite happy. I've got we had to do a lot of in-depth analysis when we're putting together the Bid for the Life Chances Fund, so I have a huge amount of information which I will edit down so people don't lose the will to live and pass on to Kate.
Excellent, that's fine. And so the next, rolling on from that, the next thing would be really, what do you feel, having done the Rewire project in North Lincolnshire, are the next steps, and how can we sort of scale this kind of service delivery across the rest of the parts of the country where it's very sorely needed?
I think the next steps are to look at the data that's in the practice. Look at doing the early intervention, having it intelligence-led. There's also, review your patients on high doses of medication would be a natural first point to start if you're not going to run an IT tool over it. Look at transferable skills. I've done a lot of work around alcohol harm reduction and embedding workers or skilling up staff members to hold the initial psychosocial conversations is not outside the realms of possibility, because from a lot of these patients, simply being able to point them to things like the pain toolkit, etc., that's enough. So the next step, I hope, will be for our pilot to be extended out, and more than happy to talk to anybody about this, because seriously, it's become an absolute passion. We've seen the difference it makes, and my personal background is in IT and big database systems. So I've seen what applying knowledge can do to change a system. It's not just about saving the money, it really is about improving the outcomes for the patients. But you can save quite a good bit of money as well.
I think there's two things that most of us would be in agreement with. And unfortunately, Graeme, we could have probably gone on with the questions that are still piling through for at least another half an hour, if not longer. However, what we will do is we will look at these questions and send them out to Graeme for a sort of, FAQ type process, and we may get a good response to some of those, which we will either send out with the web link or put up on SMMGP for you. It only remains for me to say thank you very much, Graeme, for an excellent presentation, and very thought-provoking, and I think we're all going to take something away about ways we can try and improve the services in our area, or if they're not existing, to at least try and get them started, whether that's on an individual practice level or as a sort of PCN or CCG. I'd love to thank Paul for his presentation, which was very powerful and very moving, and all that remains for me to say is thank you all, everybody, for tuning in, and feel free to come back and look at any of this again on the web link when you get it, and a very good night and a very Merry Christmas to you all. Thank you.
Thank you very much.